Good afternoon. Well, my name is Kambiz Bazadi, as Victoria kindly for the introduction. I'm an orthopedic surgeon. As you may know, I practice in this area. My area of interest and subspecialty is knee and shoulder reconstructive surgery. I appreciate the opportunity to be here talking to you tonight about arthritis. The subject matter is arthritis, which is a big subject, and I'll try to give you a broad overview of arthritis and hopefully leave you enough time at the end to ask any questions. We know that musculoskeletal conditions affect millions of people, costing in excess of $250 billion per year in the US alone. About 45 million Americans suffer from osteoarthritis. And osteoarthritis is the most common form of osteoarthritis of more than 100 types. To understand arthritis, it's very important to look at a joint and see how a joint works. Basically, a joint is where the ends of two bones meet. And the ends of the bones are covered by a smooth material called hyaline cartilage. And hyaline cartilage basically cushions the end of the bones and allows the joints to move in a painless, frictionless manner. The joint is covered by synovium, which is the cover and lining of the joint. And the synovium basically produces fluid that reduces friction in the joint. The ligaments basically connect the bones and provide stability to the joint, and your muscles and tendons basically provide the power and movement for the joints. Arthritis, simply put, is basically inflammation of the joint. And inflammation is your body's natural reaction to injury. Inflammation of the joints eventually results in visible swelling, pain, and stiffness in your joints. And when you have chronic inflammation in your joints, that can lead to long-lasting disability and permanent problems with your joints. Osteoarthritis affects the cartilage in the joints. And eventually it can lead to complete breakdown of cartilage and essentially loss of the joint. It's the second most common cause of long-term disability in adults. We will talk about some other forms of arthritis in a second, but I want you to think about the fact that osteoarthritis, the disease starts at the level of the articular cartilage. There are other forms of arthritis where the disease starts in the lining of the joint and the synovium. Osteoarthritis primarily affects the weight-bearing joints in your body, the hip, the knee, and the feet primarily, and secondarily, your hands and your axial spine, your neck and your back. Osteoarthritis affects all races equally in this country. And by the time you reach the age of 50, the prevalence of osteoarthritis increases. Women are more affected by it than men. And by the 60s and 70s, most of us have some arthritis in our joints, one place or another. As opposed to systemic type of arthritis, like rheumatoid arthritis, osteoarthritis does not affect any of the other organs in the body. The early symptoms of osteoarthritis are pain in the affected joints that get worse with activity and prolonged use. And when you rest those joints, the pain goes away. Another problem with osteoarthritis is stiffness, and it's stiffness that's relieved with gentle motion, flexing, and movement of your joints. And you should think about the fact that there's some other kinds of arthritis that are not related to activity. You have pain all the time, and that's in contradistinction to osteoarthritis, which the symptoms basically are worsened with activity and prolonged use. This is an X-ray of a normal knee, where the articular cartilage is maintained, and an osteoarthritic knee where the cartilage on the inside part of the knee is completely destroyed. And this is the typical bone-on-bone disease that you hear about. By the way, there is no blood test for diagnosis of osteoarthritis. Osteoarthritis is diagnosed clinically, and we'll talk about that here in a second, but blood tests are used to rule out or diagnose other forms of osteoarthritis. For osteoarthritis, most osteoarthritis has no known cause, and that type of arthritis is essentially classified as primary osteoarthritis. And primary osteoarthritis, you can think of it essentially as a byproduct of aging. As we age, that cartilage that we talked about, basically that cartilage is 80% water. And the water content in our articular cartilage decreases over time. And as the water content decreases, the ability of the cartilage to withstand stress decreases, and the cartilage basically falls apart. And the knee essentially goes from looking something like that to something like that over a prolonged period of time. Also, the ligaments around our knees and hips, they weaken and they make your joints more prone to injury. That was primary osteoarthritis we just talked about, the byproduct of aging. And secondary osteoarthritis is osteoarthritis that's associated with another injury or disease. And these are the three most common causes of secondary osteoarthritis: obesity, trauma, and previous surgery. Also, abnormal joints at birth, gout, diabetes, and various hormone disorders can be factors in causing secondary osteoarthritis. So what I want you to think about, the subject of our talk tonight is osteoarthritis. And just to kind of understand things better, I want you to think about osteoarthritis in two broad categories. What we're just talking about is osteoarthritis. Osteoarthritis is a sort of degenerative joint disease. It's a disease that's associated with aging, wear and tear, and all the other factors that may be associated with it, such as trauma and obesity. And I want you to separate osteoarthritis from inflammatory arthritis, which is an autoimmune disease where your body essentially attacks itself. And the most common forms of inflammatory arthritis, you may have heard about rheumatoid arthritis, lupus, and psoriasis. Another distinction to be made about these two types of arthritis, as we talked about, when you have osteoarthritis, your cartilage begins to break down and the disease process starts in the cartilage. As we talked about, the water content decreases, the cartilage falls apart. And the inflammatory arthritis, the disease starts in the lining of the joint, in the synovium, and then it secondarily affects the cartilage. When you see your doctor, for your doctor to make a diagnosis, he may take a thorough patient history, he may do a physical exam, get x-rays, MRI, and maybe other scans, such as a bone scan and a CAT scan, and your doctor may order some blood tests to rule out the other forms of osteoarthritis. It's important to do all these things to make an accurate diagnosis. The goals of treatment for osteoarthritis are obvious. The most important goal is to relieve pain, increase motion, improve strength and function. Conservative treatment for osteoarthritis may include simply rest, exercise, weight reduction, and physical therapy, also use of medications and injections. These all basically constitute conservative modalities. And surgical treatment for osteoarthritis is varied. There's multiple different types of treatment, and we'll try to touch on a few of those tonight, this evening, or this afternoon. There are a variety of medications on the market that help relieve the effects of osteoarthritis. And over-the-counter pharmaceuticals such as aspirin, ibuprofen, naproxen, these are very helpful, as you may already know, in relieving pain and inflammation in your joints. Tylenol is not an anti-inflammatory. It helps relieve pain. It works at the brainstem level to basically block the pain receptors, but it's not an anti-inflammatory. And if the over-the-counter anti-inflammatories don't work, your doctor may prescribe stronger versions of them, or COX-2 inhibitors such as Celebrex and Mobic. Basically, these medications are a little bit softer on your GI tract, on your stomach, the lining of your stomach. But it's very important to understand that all anti-inflammatory medications, when they're used for a prolonged period of time, they can damage your internal structures. They can damage your kidneys, your liver, and your GI tract. So it's very important to be aware of that. And if you're taking these medications for a prolonged period of time, you have to make sure that somebody is checking your kidney and liver function tests, checking out the lining of your stomach. And if the medications are ineffective, your doctor may talk to you about injections, and the two most common injections that we use are cortisone injections and hyaluronic acid injections. Hyaluronate is a cartilage extract. And basically, these are two injections that we use to manage inflammation and pain in your joints They're very effective, but they're not definitive treatments. And they may help provide pain relief from anywhere between 1 to 6 months. Vitamins may have a benefit in treatment of osteoarthritis. There are some studies that suggest that optimal intake of antioxidants, these vitamins A, C, D, and E, may help prevent osteoarthritis. However, these are laboratory studies. These are not clinical trials, and there's no proof that vitamins actually prevent osteoarthritis. If my patients are interested in the subject, I talk to them about it, I use it myself, and I give them my secret vitamin dose to take whenever they want to. The nutritional supplements, glucosamine and chondroitin sulfates, they're commonly used. I'm sure some of you are taking it. And patients generally sometimes report very good results with these supplements. I think that probably the treatment benefit of these supplements are sometimes exaggerated. I tell my patients that if you've taken them for 2 to 3 months and you seem to get some benefit, there's decrease in your symptoms, that you should continue to take it. But if you've taken it for 2 or 3 months and you haven't had any benefit, you could probably save your money and not buy more of this stuff. And literally there are 50 million people who are using it, and there are 50 million people who say it's worthless, it's not helping. Alternative medicine, alternative therapy options are essentially great in number, but their effectiveness is really unclear. In my view, alternative therapy has some role and value in that it helps you get involved in your own healthcare. And when it does that, it may help you ease your symptoms with respect to pain, stress, depression, and anxiety. It can improve your outlook and attitude, and it will not generally replace proven medical treatment for osteoarthritis. Joint protection is simply common sense. Those of you who may have an arthritic knee or arthritic hip, you may do something, too much gardening or too much walking, and have a flare-up. And simply staying off your feet for a few days or using an assisted device like crutches, walker, or cane for a short period of time can provide relief to that joint, decrease inflammation, and decrease pain. And that is sometimes all it takes to decrease a flare-up in a joint. Exercise can have great benefit in osteoarthritis. It can help strengthen the muscles around the joints, prevent stiffness. It could reduce weight and promote endurance. But it's important that if you exercise, what Victoria was talking about, to maintain strength and mobility, that you don't do too much or create a flare-up in your joints, because it's very easy to create a flare-up. And every person has a specific limit or physical limit. And if you keep yourself under that threshold and keep your muscles somewhat exercised and strengthened, it's a helpful thing for you. If you don't move, you're going to get progressively more stiff and more painful, and it's harder to get you moving. So you should always try to move, but stay within that physical limit that each one of you has, and you know what it is. So you may be able to walk. And by the way, Victoria, there's nothing like walking. And I think that walking is the best exercise known to man. If you can walk, it's better than your biking and swimming and all these machines in the gym. If you can walk half an hour a day and do it every day without creating a flare-up, you should do that. And some people can walk an hour a day, some people can walk 15 minutes a day. But my sense is find that threshold and keep it going, and it's a good thing for you to do that. Surgery may be indicated in treatment of your arthritic joints, and broadly, these are the categories for surgical treatment: arthroscopy, osteotomy, cartilage restoration procedures, total joint replacement, and the new technologies that go along with joint replacement surgery. Arthroscopy is the least invasive procedure that we do for osteoarthritis. It's essentially was used to call keyhole surgery. Basically, the surgeon goes inside your joints. It could be your shoulder, your hip, your knee, or ankle, and through little incisions, or what we call portals, removes the partially damaged cartilage. The concept is to basically go inside the joint and find these broken pieces of cartilage, broken debris that create an inflammation in the joint. So if you clean up these broken, dead pieces of cartilage, you may prevent these recurrent bouts of inflammation in the joint. This is an operation that may help you or it may not help you. It's completely unreliable operation for arthritis. It's an operation that we frequently do for meniscus tears or ligament injuries, and it's very useful for sort of that type of sports medicine type operation. But when you're doing arthroscopy for arthritis, you have to understand that this operation doesn't change the big picture with respect to your knee. It's really a camera, fancy camera that goes in the knee with some tools to clean things up. It's really called essentially a cleanup procedure for arthritis. There are other surgeries that we do arthroscopically, and microfracture chondroplasty or abrasion drilling. It's a type of procedure that we do arthroscopically, and this is more indicated for sort of small arthritic lesions, especially about the knee. So if you have an arthritic lesion that's small and localized and focal in the knee, and you drill that or do what's called a microfracture, you will stimulate a healing response, and that can create a fibrocartilage or scar cartilage. And scar cartilage is better than bare bone, but it's not as good as your normal cartilage. And sometimes this type of technique helps when you have sort of more localized and smaller arthritis. Osteotomy is an operation that basically was very favorable and very popular in the 60s, 70s, and 80s, and it's become less and less popular over time, but people still do it. But the concept of osteotomy is basically to sort of realign the bones around your joints. So to realign your joints, so to speak, to put your weight from somewhere where you have a lot of arthritis, throw it to the side that you have less arthritis. I will tell you that even though people do this operation, in my view, has fallen out of favor. And people like myself who do joint replacement, we don't like this operation very much, because when you alter your anatomy, you take a piece of bone out and do this type of procedure. When it comes time to discuss joint replacement surgery, this makes your joint replacement surgery much more difficult. So people are doing this operation less and less over time. Articular cartilage restoration procedure. These are procedures that are mostly indicated when you have more localized arthritis, particularly about the knee. And there's two sort of broad categories of these type of procedures. What I call the Oates type procedure and a cartilage transplant type procedure. Patients always ask me about this, even patients who have bone-on-bone arthritis and need a knee replacement. So let's talk about it a little bit. If you have a sort of a reasonably small lesion, this is a sort of area of bone exposed in the knee that may be an inch in diameter. A small lesion that's focal, what I call geographic. It's got borders, the rest of the joint is healthy. You may consider this Oates type procedure where you basically go inside the knee and borrow a plug of cartilage and bone from an area where you don't need it as much and transplant it to an area in a defect in your knee where you need it, where you're weight bearing. So basically you're transplanting cartilage from a non-weight bearing area in your knee to a weight bearing area. This is not for a big lesion or severe arthritis in the knee. It's more, again, for these sort of more localized, smaller lesion. ACI, or cartilage transplantation procedures, and its various forms basically involve harvesting cartilage. When you do an arthroscopy, you can harvest cartilage and send it to the lab, and those cartilage cells can be grown in a petri dish, just like bacteria grow in a petri dish. You grow the cells, and you go back in the knee with a second operation, and you use those cartilage cells to fill in the defect in the knee, very much like filling the pothole in the road. Again, this operation, the one previous, the Oates procedure, was mostly for small or localized arthritis. And if they're done for the right patient, for the right indication, they may prevent progression of arthritis in that patient. So there's a place and role for each one of these operations. Total joint replacement is considered the definitive treatment and final treatment for advanced arthritis in the hip, the knee, and the shoulders. Basically, improved ambulation and decreased pain is the most desirable aspects of these operations. And for those people who undergo total joint replacement, about 90% can expect good to excellent results, just from a statistical perspective. So in a knee replacement, basically, the end surface of your femur or your thigh bone and the end surface of your tibia or your shin bone is removed. Those bone cuts are made. A metal implant is placed on the femur. A metal implant is placed on the tibia and a plastic insert. Your kneecap is also replaced with a plastic-like material like that. With hip replacement, the concept is essentially the same. Essentially, your hip joint is removed, and the hip socket is replaced with the hip is removed, the hip socket is replaced with a metal cup, a plastic liner is applied, the hip femur is replaced with a metal stem and a metal ball, and the hip is reduced to produce a hip replacement. In the United States, there are about 600,000 knee replacements that are done annually, and about half of that number of total hip replacements, I think 285,000 hip replacements a year done annually. Now, there are other forms of joint replacement that we can consider, especially if we can catch the arthritis condition in its early to mid stages. For example, particularly with the knee, if we catch your arthritis in its mid stage, and the knee has essentially 3 compartments to it, 3 sections to it. If we catch it at a stage where one compartment is arthritic and worn out, but the other compartments are healthy, we can consider a partial knee replacement. And so, especially with the knee is like, I call it sometimes a tricycle. There's like 3 different sections to it. The inside, the outside, and the kneecap. Most people, as they age, they become slightly bow-legged. So for most people, the inside compartment is worn out much more rapidly than the outside compartment. And actually, we can do a total knee replacement, replace the whole knee, like we just showed in that video clip, or we could do a partial on inside, outside, or the kneecap. Some of these operations are a little bit more popular than others, and some are a little bit more successful generally than others. We'll talk about that as well in a second. So you can see when we talk about osteoarthritis from a surgical perspective, we have a variety of operations that we offer for the patient as we catch that arthritic condition in its evolution through time. And so if we find somebody who has sort of a more localized arthritis in the knee, for example, we may do an arthroscopy to clean up that lesion, do that microfracture, and maybe consider one of those cartilage restoration procedures like the OATS or cartilage transplant. If we find that the whole compartment is gone, but the other parts of the knee are healthy, we may do a partial knee replacement. And if there's advanced disease in the knee joint, we basically move straight to a complete knee replacement or a total joint replacement. And this brings us to the concept of new technologies in joint replacement surgery. Basically, we know that with the evolution of any industry, there's successes and failures in that industry. And when new technology comes to the market, as orthopedic surgeons, we always want to use that technology because we want to do a better job and get better results for our patients. But as a community orthopedic surgeon, I personally myself, and I think my fellow orthopods in the community, we don't have the luxury in jumping in and trying out every new technology that comes to the market. So for us, it's very important to make sure that whatever technology we adopt has been out there for a while and it's been rigorously tested and has some track record before we adopt it and start using it on our patients. And in that light, I want to share with you a technology that's recently become available in this hospital, and that involves use of robotics in joint replacement surgery. So we're going to go back to this kind of partial knee replacement that we just talked about at the end. Partial knee replacement surgery in the United States and in Europe is not as popular as total knee replacements. And if you just look at the numbers, there's about 600,000 knee replacements that are done in the US on an annual basis, and about 50,000 partial knee replacements. And I think the reason for that is because partial knee replacements are more difficult operations to use or to do with conventional instruments. And because you have to get these 2 components aligned, if if you remember your geometry class, and the X, Z, Y, and Y axis, and aligning and matching those components is a very difficult task, even in the hands of a very skilled and experienced surgeon. So this type of operation, which conceptually, theoretically has a lot of value, is harder to accomplish with standard instrumentation. And with robotics, which is sort of a new technology that's come to the forefront here now, this type of technology helps the surgeon do this operation better. Because if these components are not matched together perfectly, and they're not basically moving in the right position with each other, particularly if they're misaligned, they will fail and collapse. So speaking of robotics, this is a sort of a new technology that I've been watching perhaps for the last 8 years. I think that it's developed a good track record. It's safe, and I think it's ready for prime time. It's recently become available in this hospital thanks to the vision and leadership of the hospital here in San Ramon. This is something that they've provided for us so we can do this type of operation for our patients, especially when this operation is indicated. So Makoplasty, or is just the name of the company, but basically it's a surgical technique that involves a robotic tool that helps the surgeon do the surgery. And basically what it does is that it gives the surgeon a tremendous amount of information that he didn't have before, and that information helps the surgeon, him or her, to align those components much better, much more perfectly than he could have ever done before. It helps the surgeon in resection of the bone, alignment of the prosthesis, and ligament balancing. And this is just an animation of this robotic computer that we use now to do partial knee replacement surgery. Right now, I think this technology is ready to go, ready for prime time with partial knee replacement, and I believe in the future it will be more adopted for the bigger operations like the total joint replacements and total hips and total knees. And again, these are just kind of animations of how this machine works. It's essentially, again, it's a robotic tool that's controlled by the surgeon and basically helps with precise resection of the bone. Once the bone is resected, of course, the prosthesis is placed in sort of a standard manner, and this kind of animation of how a partial knee placement is applied to the inside of the knee. So in summary, with respect to this new technology, again, this is the beauty of this technology is that you can see in virtual reality and in real-time information the relationship of these components on the end of your thigh bone and the top of your shin bone, and you can see the relationship of these components throughout the range of motion, which helps you fine-tune the position of these components, and that helps you get a bit better results for the patients. Again, this is as I said, this is an operation that helps with positioning of the components and balancing of the soft tissues and the ligaments. And I think with this technology, your surgeon can probably do a better job than he could have ever done before with partial knee replacement. Again, this is something that I think is going to help this particular operation, and in the future, hopefully help with the bigger operations. So in summary, osteoarthritis affects in excess of 40 million Americans, and you may be probably one of them. And the accurate diagnosis is very important. It's important that I think you understand as much as you can about your condition. As you know, there are many treatment options available. And I think you should talk to your doctor to find the benefits and limitations of each of these operations and treatments, conservative and surgical treatments, to choose the right treatment for you. Thank you. Thank you.
Thank you, Dr. I didn't hear you mention anything about the not yet very prime time things like stem cells, nanoscaffolding, rebuild cartilage. Is that 5 years out?
It's a good question. So that's not ready for prime time. So let's go back to that. Let's go back to this picture. And because your question is along the lines of what I call articular cartilage restoration procedures here, ACI. So this is kind of the Wright brothers stage for cartilage transplantation, where you basically take cartilage. Cartilage cells are alive, and you grow them like you grow bacteria. You grow 4 million cells, and you come back and you find that defect, which may look something like that, and you put a patch on this, and you inject those cells in there. Now, the next step in evolution of that process is to get stem cells to become cartilage cells and differentiate in that manner and not have to do this two-operation type of thing. Because right now, it's a two operation. Go in, scope, harvest, grow it, and come back. But perhaps in the future, you can basically harvest some bone marrow or get stem cells at some point in time and get it to differentiate into a cartilage cell, grow it, and then do that. So this thing is evolving. Using that technology for localized lesions like this is reality perhaps 5 years. Using it for this, I'd say 10 years. I'm just guessing. But using that type of technology to resurface a whole compartment, I think is far away, but people are working on it.
What's the difference between osteoarthritis and osteoporosis?
It's a great question. Osteoporosis has nothing to do with your... I'm sorry. Yes. The question was, what's the difference between osteoarthritis and osteoporosis? Well, osteoarthritis involves your joints, your hip, your knee, your feet, your back. It's the joint, not your bones. And osteoporosis involves the internal structure of your bone. Okay? So osteoporosis has nothing to do with your movable joints. Basically, it has to do with the mineral content of your bone. So let's talk a little bit about osteoporosis. Okay? Every person that you know is going to get stronger with the bone until the age of 35. After 35, it's downhill. Okay? It's a fact. Now, what you can do to fight osteoporosis is to be weight-bearing. That's why I don't like as much stationary bike, pool, Stairmaster, because you're not weight-bearing. So walking is a beautiful exercise. It's much better than the other things that Victoria was recommending. Just kidding. The reason it's beautiful is because you're weight-bearing. And it works on your skeletal system, and it combats osteoporosis. It combats the washing out of your bone of mineral structures. So you should walk and be weight-bearing to the extent you can. And I'm not saying don't get in the pool or don't get on the stationary bicycle, but I think walking has more value and benefit for you than these other non-weight-bearing exercises. You had a question.
Well, I have a couple questions. One is, when do you make the decision of partial versus total?
It's a great question. Yeah.
Is that a...
This is a very great question, and we're on the right slide for that.
So
you use
laser surgery?
Yeah.
I'll get to you in 1 second. Let me answer his question, and I'll get to that in a second. Partial versus total. Arthritis, as you may have figured out, basically evolves over time. So if we can catch you in its evolution at its mid to early stages, and we can catch you where sort of the inside part of the knee is bone on bone, the outside and the kneecap is healthy. The kneecap area is healthy, the inside is worn out, and typically what it looks like on the x-ray is and the inside is bone on bone, and the outside is pretty healthy, and you have preserved cartilage. And it's same thing with the kneecap area. And that person can have a partial knee replacement. And I think partial knee replacement is something I've been doing for 19 years. And most recently, I've been more interested in it because, as I say, very skilled surgeons had a hard time matching those two processes together with the instruments. And now we have sort of the tools to kind of match them together in a much better way. And the concept and idea is that if you do a partial knee replacement, you may still require a total knee replacement down the line, but it may also salvage your knee, kind of prevent the progression of arthritis down the line. Because most certainly, and I've seen this in practice over a period of time, when you have bone on the inside and you're walking around doing those things, I say hi to you every year, eventually the whole joint is gone.
And now finally, another question is, which will last longer, total knee or what's 5, 10, 15 years?
The studies right now show that total knee replacements have better long-term results. But I think that's because we have not been able to do the partial knees in a better way, okay? But the materials and the designs are good. They've certainly improved over time, especially somebody was asking about the polyethylene here. So the designs are better, the materials are better, and I think there is no guarantee. All prostheses can fail. But I think if they're mechanically done in a good way, they're probably going to last you a lifetime.
And then, so some of this sounds like an outpatient.
You could do this in an outpatient procedure. I generally may keep you a day or two after a partial knee replacement. I usually keep you at least 3 days generally, or sometimes people will come back for their second total knee. I may send them home on the second day because they've already gone through the whole class and they know what's going on.
And now, I'm sorry to hog the stage, but finally, it's the recovery time's got to be a lot shorter.
Recovery time for partial is shorter than total, but it's still a big operation. It's not an arthroscopic procedure. And so one of the things that we've been doing, you know, if you had come to this talk 10 years ago, we'd be talking about minimally invasive surgery. But basically what we're doing right now is doing these operations and not going through the muscles as much. So you kind of get your soft tissue control much quicker, but it may take up to a year to recover from total joint replacement. You may be walking up to 2 miles in 2 to 3 months, okay? So you still continue to recover. Basically what's happened now, because we don't go to the muscles that much, you recover pretty quickly the first 2 or 3 months, but you continue to improve over the next 10 months. In the past, if you had it done in the 1990s, you would improve like this, okay? Now you improve more like that. Now we got to get to his question. Laser surgery. What do you mean exactly by laser surgery? Like heat surgery? Is that what you asked? Lasers?
Yeah, lasers.
Laser, okay. So basically, the only time we may use, we may refer to this as laser, but it's really not laser surgery. But remember we talked about arthroscopic surgery, where you go into small holes inside the knee? Remember that? So when you clean up cartilage that's broken down, let me go to this slide. When you clean up cartilage that's broken down, this slide, okay? This is the end of your thigh bone that's broken down cartilage. And the way you clean that up is 2 ways. One is by a mechanical shaver. It's like a roto-rooter, you know. And the second way you do that is by laser heat. It's just heat now. Now, when I was doing my fellowship in Utah in 1994, it was actually laser, but lasers are not used anymore in orthopedics, period. And the reason is because if you use heat, you can clean up this cartilage really nicely, but when you use laser, we found out over a period of about 5 years that leads to, it basically does more damage to deeper tissues or the bone. It actually kills the bone. So the true answer to your question is laser is not used in orthopedics at all, but heat is used. You had a question there.
Yeah, you've been talking about osteo. What about rheumatoid arthritis? For surgery, is that a no?
No. It's a very good question. So the rheumatoid arthritis, so what happens with rheumatoid arthritis? Eventually, the joint is lost as well. Eventually, but the process starts in your synovium. And basically, through these repeated bouts of inflammation, the cartilage eventually gets lost. So you end up with like an osteoarthritic patient with a completely lost joint. So we do the exact same operations for a rheumatoid arthritis patient as a osteoarthritis patient. Okay? You may end up, because the process of rheumatoid is more systemic and it involves the soft tissues around the joints, typically what happens is that the ligaments get more damaged, the joint gets more damaged, you may get more deformity, but the end stage is that your joint is destroyed, even though it started in a different manner, and you have the same treatment options available to you as an osteoarthritic patient.
Everything applies.
Everything applies to you, absolutely. Everything we said. Now, especially with resurfacing operations like joint replacement, everything I said applies to you, except a few things. Let's go back. Okay. The partial knee replacement does not apply to you. Total knee replacement and total hip replacement and total shoulder replacement, they all apply to you. Arthroscopy applies to you. Osteotomy, which I don't like that operation anyway, doesn't apply to you. You should never have that done. But you can have an arthroscopy, sort of a cleanup procedure, maybe a temporizing procedure, and eventually you need a total joint replacement.
Sooner or later.
Sooner or later.
I'm going to go to a total joint, no matter what.
Absolutely, absolutely. Okay.
I have a question, and I'm going a little bit more basic than surgery. Can you tell what is going on with the body when you're clicking? You actually hear clicking noise when you move. And my other question is, you talked about flare-ups with repeated motion and all. What can you tell from a joint hip that hurts when you get up in the morning, when you have been off it for 8 hours? What does that mean?
Okay, let's take it one at a time. The clicking, does the clicking hurt?
No, the clicking doesn't hurt.
Don't worry about it. Because clicking could be caused by a variety of factors, okay? And especially in our bodies, you can click because tendons snap over joints or because we have bursas inside our joints, like particularly shoulders click and pop a lot. No pain, probably no pathology. I wouldn't go worry about that whatsoever. The second question was the hip. We wake up in the morning, the hip hurts. Well, it could be a variety of things. It's kind of like telling your mechanic, there's some smoke coming in the front of my car. It could be anything, but it could be your hip joint, it could be a bursa, and it could be your L1, L2 nerve root. It could be any one of those. Just to give you some information, if you actually feel the pain in your groin, it's much more likely to be our arthritic hip joint. But if you feel it here, and people say, this is my hip, that's not your hip, okay? That's your back. And that's more likely your lower lumbar spine, okay? And we all of us, we get arthritis in our neck and our back. And this is just plague of humanity. You cannot escape it, okay? But I think what yours is, if you feel it here, is your lumbar spine.
On the side.
On the side. And you can have the bursitis. Bursitis. And when I see my patients, if I touch here and they jump and it's bursitis and I get an x-ray, they don't have arthritis, I may give them medicine first, not too long. I don't like to give anti-inflammatories for more than 2 weeks. And I may give them an injection there. And if it's a bursitis, it's a wonderful thing. It helps quite a bit. Sure. Go ahead.
Under what conditions in the diagnosis process would you use the MRI and not just the X-ray?
Okay. Well, that's a good question. A lot of people may show up and say, I got my MRI here, so let's go from there. So it's important to realize that MRI is just a piece of the puzzle, particularly to the orthopedic surgeon. We get a lot of information from x-rays, and the x-rays we get are very specialized, those of us who do hip, knee, and shoulder surgery. We get specific views to find out what's going on with your joint. For example, this x-ray right here, okay? These x-rays are weight bearing. That means you're standing with your knees bent. So if you go to your emergency room doctor and say, my knee hurts, they may get an x-ray of this knee and it's going to look like that if you're not standing or weight bearing. MRIs are very useful for soft tissues, your ligaments. If you tear a ligament or a soft tissue, you tear a meniscus. But it also gives information about the internal structure of your bone because the bones get involved. So X-rays really give us very specific information about the cartilage and the joint. And MRIs give us information about the soft tissues, ligaments, meniscus, and the internal structure of the bone.
So I have another question. For hydrocortisone, sugar.
Yes, yes.
And for people with diabetes, is a problem. So what is the
Okay. So when you get a cortisone injection or you take cortisone orally, what it does, it throws your sugars off kilter. So I don't generally, I ask if I see diabetes and what they take, particularly somebody who has what we call brittle diabetic, who's on insulin, I ask the patients how is their diabetes? Are your sugars well controlled or your sugars out of control? A lot of people don't pay attention to the diabetes the way they should. So if the patient says, well, I don't pay too much attention to it, I may not give them a cortisone injection. But typically, a person who has diabetes who's well managed, they can get a cortisone shot. Their sugars, if you watch them on a graph, let's say they're 100, okay, they're well under 100, and they may bump up for a day or two to 150, 160, and they will settle down after 2 or 3 days. So it's not what we call contraindication. There's no, you can have it, but your diabetes has to be well managed.
What about the other injection? It was hyaluronic.
Hyaluronic acid. So hyaluronic acid is sort of a natural compound in your knee. So basically, hyaluronic acid, so we talked about the fact your cartilage is mostly water. You have cartilage cells, there's a lot of water, 80% water. You have these sort of collagen fibers and some elastin fibers, and then these proteoglycans. Hyaluronic acid is part of your cartilage. And we found at some point in time that we injected in the knee, it decreases inflammation. There's a lot of advertisement, lubricants, DW40, that's all nonsense. All it does is decreases inflammation in the knee, but it does it in a different way than cortisone. And I'm not sure we know exactly how that mechanism is, but the inflammation decreases is very helpful for some people. Some people get it, it doesn't help them at all. Some people get it, it really helps them. They come back every 6 months to a year to get repeated injections. They used to be done 3 weeks in a row. Now we get them all in one ampule. We give it to you all at once, so you don't have to go to your doctor 5 weeks in a row.
Is injection good for hamatoes?
For pain or for deformity? You mean?
Painful, yes.
Cortisone injection is, people refer to it as like a magic bullet. Okay, you get it in your hammer toe, your pain will probably go away. It's really the most effective way of diminishing or decreasing inflammation. So I'm not sure it's good for your hammer toe, but it will definitely help your pain. I would not recommend it to you, and I don't think your foot doctor or your podiatrist would recommend it. One thing about cortisone is that we don't just give it everywhere. The orthopedic surgeons don't, especially in a tendon. So if I give you a cortisone shot in your shoulder, it's very carefully put above your rotator cuff, not in your tendon. It's not a blind shot. I use an ultrasound to see where we put it. So sometimes people give a lot of cortisone shots, and if they put that cortisone shot in your tendon, like in your hammer toe, that tendon will rupture. Bang, it's like a cable that goes like that. So in my view, I don't think that That's a good thing for hammer toe. If you have a hammer toe, you should see a good podiatrist, have a great partner. There's a good podiatrist, he'll take care of that for you. But don't get injections in your hammer toe.
You also did not mention the platelet-rich plasma injection as good for hyaluronic acid.
Very, very astute. Let's talk about PRP. It's not FDA approved. If you're Tiger Woods, you can go to Canada and get 8 PRP injections here and there and there. And people do that, and people ask about it. But basically, let's talk about that a little bit. Platelet-rich plasma, we could draw your blood, spin it, isolate the platelets and its associated growth factors, and inject it anywhere in your body. For most orthopods, you may have had tennis elbow or elbow pain or shoulder pain. That has been the sort of the biggest indication for PRP or platelet-rich plasma. And there are many recent meta-analysis studies, big studies, that show it is not that effective, So there's two things about it, is that there's no strong science to support it, even though conceptually we think it should help. Two is that insurance companies don't cover it. So if you want to get it done, you can get it done, it's going to cost you $500. Okay, and are you going to give $500 to do something? Some people would like to do that. They just read about it. They say, here's a professional athlete who did it, and I want it done. So I generally kind of refer them to people I know who like to do that. But if the procedure doesn't have strong science behind it, I typically don't use it. Especially PRP inside a knee joint. It's a shot in the dark.
C-reactive protein shows in the blood.
C-reactive protein is a marker of chronic inflammation. It's inflammation or infection. Okay, so when we are trying to kind of monitor both of those things, but it's a very sensitive test, but not specific. That means that it doesn't tell you if it's one or the other. But if we are trying to, for example, monitor a patient who's got an infection, and we want to see that the infection is going away, over a period of a year, every month we get a C-reactive protein. We'd like to see that number come down like that to become normal eventually.
And with a knee replacement, how long does that replacement last? Someone told me it can't happen more than 6 years after life 6 years.
Well, I think that if your knee replacement is done very well, it's going to last you a lifetime. Okay? A lifetime. A long lifetime. And I think that, so there's a couple of factors involved here. One is the material, the design. Two is your surgeon and the surgical technique. How well is that? Knee and hip replacement is not just a sort of science, it's a combination of science and art. You get better, you do this, you get better. If your surgery was done well and your knee is not loosey-goosey and all over the place, I think that knee will last your lifetime. Now, when I was doing my residency years and years ago, in the early 90s, we would tell the patient this will last, the party line was this will last 10, 15 years. And people still say that, but I don't think that's the case. I think if the joint replacement is done well, it's going to last you a lifetime. Okay. Now, that's not to say there are not failures with knee replacement or hip replacements. We still have problems with these things. Sometimes it's because of the material that's being used. Sometimes it's because the work was not done very well. Things are malaligned, and those things eventually lead to failure.
Yes.
If you had early teen sports injuries that led to early osteoarthritis, and you're told eventually you're going to need a knee replacement, but you're not looking at, what age is optimal for a knee replacement?
You're way too young to have a knee replacement. But look, I think the way we approach this nowadays is different. Even though we have some hesitation recommending a knee replacement to somebody your age, we're looking at your quality of your life. Okay? If you're hobbling around day in, day out, you're in pain, you're popping Advil and Aleve and dabbling into pain medicine to deal with your arthritic knee, and you have that type of x-ray, it's a no-brainer. You need a knee replacement. Their age is not an issue, okay? And I think that's a little bit different than I say the late 80s and early 90s. It was heresy to say knee replacement in a 35-year-old. People do that right now all the time.
Going back to your hydrochloric acid statement, people share their home remedies when they come and have something going on, and there's a talk right now that's speaking of something at home. Is this supposed to be good for the job?
Yes, I thought you were going to talk about whiskey and raisins, but okay. So rooster combs is the same as that hyaluronic acid, okay, because we first came upon that finding when it was rooster combs. It's actually made out of rooster combs, hyaluronic acid. Now, because some people have had reactions or allergic reaction to that, that material is just synthetically produced, hyaluronic acid. So I don't think anybody uses the rooster combs anymore. I think all the companies basically produce it synthetically. But hyaluronic acid that we inject is what you're referring to as rooster comb.
In active treatment or coming off of active treatment for autoimmune disease, we're told that it's not good to take a steroid.
Absolutely. You know, if you're taking medications for autoimmune disease, those drugs or those medications, what's referred to as disease-modifying drugs, those medications are very strong medications, okay, that your maybe oncologist or rheumatologist prescribing for you. And you don't want to mix those medications with steroids that your orthopod is giving you without the person who's giving you those medications being in complete control. And generally, yes, you don't want to be taking, because steroids decreases your immune function even more. So you may be taking that's already suppressing your immune function, and you take another medicine that depresses your immune function, then it predisposes you to infections and stuff like that.
What's the recovery rate on a hip replacement compared to a knee replacement? I mean, is it another year? Or is it...
Recovery rate, you said? I mean, which one recovers faster than the other? It's a good question. So it's interesting that basically both categories would usually kind of plateau at about a year. Knee replacement is a more painful operation for most people. It's just more difficult. And the reason is because there's a lot more nerve branches going to your knee than to your hip. And people with hip replacement they look just better after hip replacement. They don't take as much pain medicine, walk around, no pain. They seem to be recovering quicker. But as far as the soft tissues are concerned, I think that they're still recovering. They're weak. Okay, so they seem to be recovering earlier, but a hip replacement, if my patient wants to ski or do something dangerous, I don't let him do that for about a year. The same thing with the knee. But at the end, at about 9 to 12 months, they kind of plateau with each other. Somebody had a question.
I hope this is a okay question to ask. How does one go about the process of deciding which doctor to use for either knee or hip? And as far as the research on the doctor and how can you get done, what your success rate is, what your failure rate is, etc. And my apologies for
It's a difficult question to answer. So I think most of the joint replacement I do a referral by patients. I don't advertise. This is a talk I'm doing really as a community hospital for you. There are basically a group of doctors who just do joint replacement. This is all they do, and they advertise for that. And sometimes you may walk into that organization, it's like a factory, okay? This is not my practice. And I think that The best way to answer that question is really, I think, by word of mouth. When you get on the internet, you get lost in this virtual world, and you don't know what's true and what's not true, okay? So that's a difficult thing. And sometimes I see patients who come to me, but they see something fancy on the internet, go somewhere else, and they come back a year later with a painful knee. So this type of stuff happens. But basically, I think if your surgeon has been in practice, has been doing this, and you hear it from word of mouth from the patients around, that's your best bet. Because what you hear on the internet or somebody who spends a lot of money advertising their program, that's really not necessarily the best thing you're going to get. And believe me, there's tons of patients out there that would tell you that. Okay? So I think the best bet is word of mouth. Just ask around. And it's all kind of difficult because I see patients who come in and they ask me how many do I do, and I tell them, well, I may do 150 knees a year or 200, whatever, but I tell them that the number of knees I do has nothing to do with the quality of the knee that I do, okay? And people sometimes think that somebody who does 2,000 knees does a better knee. It's not the case. And I think, in fact, you may find that somebody who runs that type of a factory setting doesn't do as much of a quality work as some of the other community surgeons here who spend their time with you and basically are focused on doing a good job.
If you need a knee replacement and then the other knee need pothole surgery, how would you time that?
I would go after your knee that's more symptomatic. And the knee that needs arthroscopy, if you have a sort of a mechanical meniscus tear, okay, there's an obvious meniscus tear on your MRI, something mechanical, you could go after that first. But surgery has general principles. One of the principles is don't operate on somebody who doesn't have pain. Okay.
Very good.
You have bone-on-bone arthritis, no pain, I'm not going to touch you. Then I can cause pain for you. You could say I had 0 pain and I have 5% pain. I have a good-looking X-ray. But you should go after the knee that bothers you the most. That's another principle of surgery, is that whatever is bothering you the most, and you may say it's 50-50, but whatever is bothering you the most, you should go after that. Blood clots are a big problem with hip and knee replacement surgery. And I think it's something that's come to the consciousness of orthopedic surgeons, spine surgeons, OBGYNs more and more. It's just come to national consciousness. I personally am such an obsessive compulsive person, I will do blood tests on you before to make sure that there's no genetic predisposition. I just do that because I found out that there are a lot of people, and I would say maybe in easily up to 20% range, that have some genetic predisposition to blood clots. And I think to myself, I really don't care, I want to know that before. But almost every orthopedic surgeon will put you on some regimen, okay? Blood thinner. It could be Coumadin or Levinox or Xarelto or aspirin. You will be on something, and everybody is aware of that. But that's a risk that is not zero risk. You have that risk with those particular surgeries.
I was going to ask about methotrexate. Rheumatologist bodies there.
Yes.
What good is that?
Well, you're going to have to ask a little because that's not my area of expertise, but I would put methotrexate in what we call disease-modifying drugs. It's a heavy drug. It's something your orthopedic surgeon will never prescribe for you. What good does it do is what she was talking about. It basically controls your body's sort of ability to attack itself. So when you have this kind of what we call inflammatory arthritis where your body attacks itself, methotrexate and all these other disease-modifying drugs basically stop your body from attacking itself. It is kind of like steroids. Basically, again, they control this inflammatory attack on your body. And sometimes they have to use that, because if they don't use it, it just destroys your joints. So methotrexate and Enbrel and all these other drugs out there, a whole bunch of drugs that the rheumatologists use are intended to control sort of the disease process of rheumatoid arthritis. Stiff muscles?
Stiff muscles or arthritis.
Where do you have stiff muscles? In your legs? Hold. I'm very stiff too. I try to stretch every day, but absolutely, there is a big relationship between stiff muscles and arthritis. So let's talk about that. The one thing that happens for sure with you is that you will get arthritis in your neck and in your back. And that kind of arthritis basically affects the nerves that go down your arms and legs. And especially the hamstrings, these muscles in the back of your thigh, they are very much affected by the amount of arthritis that's going on in your back. As those hamstrings become stiffer and stiffer, your posture gets worse and worse, and you become stiffer and stiffer. So stiffness is a big problem in our society. It's related to osteoarthritis, but it's mostly related to the fact that we're not active enough and we're not stretching. I mentioned to Victoria, walking is number one. And I think she mentioned yoga. Tai Chi. Movement exercise is number two. Stretching is very important, okay? And it's very important for people my age, your age, and younger ages. So we don't stretch enough. We just sit in a chair all day long. So we're going to get stiff, okay? So stiffness can be a problem in and of itself, separate from osteoarthritis, but it's typically related to the arthritis in your neck and your back. Yeah, so if you're stiff, what I recommend sometimes to kind of jumpstart you to see a therapist to stretch you, give you some home exercises. Once that happens, you should be moving, and then you can take some Tai Chi classes or light yoga or Pilates or something like that. Movement classes, basically. It's very important.
Yes, I just wondered if you've done any surgeries on people with fibromyalgia. I'm a little concerned about going through the surgery because of the fibromyalgia pain.
What kind of surgery?
Knee surgery.
Fibromyalgia is a grand diagnosis. It's a big diagnosis, and basically, you should in your mind somewhat separate fibromyalgia from osteoarthritis, okay? Because fibromyalgia means muscle and fascial pain. The muscles hurt around the knee and stuff. And you can have fibromyalgia and you can have osteoarthritis. If more of your pain is coming from your fibromyalgia, you can have a knee replacement and your fibromyalgia or myofascial pain will still be there. Okay, so this is very important to know that the component of your pain that's from your arthritis is worse or is bigger than your fibromyalgia pain. I typically have this discussion with my patients about knee replacement because a lot of times they have quite a bit of arthritis in their back. And if your L2, L3 nerve root is compromised or pinched, you will feel knee pain from the nerves in your back, okay? And I know that because sometimes the pain goes all the way down their calf and their foot and ankle. In that person, you could do a perfect knee replacement, they will still have the leg pain, okay? Some of these patients go to those famous doctors and then I come and see them. I went to the most famous doctor in the world, right down the street. I have pain, and they have severe arthritis. So the pain in your body may be multifactorial. It may be mechanical from your knee, it may be myofascial from your muscles, and it could be nerves from your back. So you talk to your doctor to kind of have a sense. In my view, if it's 50% or more from your arthritis, and you feel the pain just locally around your joint line, and you got maybe a cortisone shot, the pain disappeared for 2 weeks, that's a go. Okay? If you got a cortisone shot in that knee, the pain didn't change, that's a sign for concern. It's a question mark.
This problem that whatsoever is my doctor recently had an accident on my shoulder and on my knee. And the report came that minor degeneration.
Uh-huh.
Minor degeneration.
I got that. And your question is?
Pardon?
What is your question about that?
So what does it mean, minor degeneration?
Are you having pain in your knee and your shoulder?
I do not have pain at all in my body,
Okay. Yeah,
except these two guys.
I would expect you to have arthritis in all your joints. Okay. So minor degeneration, in my view, is a passing grade. I wouldn't worry about it if you have pain. Nobody's going to do anything about it. So I would remember we talked about the fact that primary osteoarthritis is a byproduct of aging. Our cartilages degenerate over time as we age. The water content goes away. It falls apart. So if you have minor degeneration at this point, you should be happy. Okay. No medium meniscus and no, I'm sorry. Question was, you do water work instruction.
Am I not in the water? I'm out.
Outside, okay. And you have no medium, did you have surgery?
Nope.
So they said you had a meniscus tear.
No, it's gone.
Okay. But no surgery?
No surgery.
Okay.
And no ACL.
No ACL. So that fragment of meniscus, when it tears, it can kind of degenerate, but the residual structures, dead tissue is still there to some degree. It's not gone and disappeared by itself. But your ACL will go away. So the question was, I tore my anterior cruciate ligament inside and I tore my median meniscus, but she's an instructor, she does water aerobics outside. She's not in the water. Should you be concerned? The answer is, when you don't have that main ligament inside your knee or ACL, and typically, for most people, if they're doing straight ahead at walking or activity, even running, they may not know they don't have an ACL, but as soon as they pivot, plant, or change direction, you may know your knee gives out on you, okay? Your tibia pops out and pops back in. So without that ligament, the ACL inside your knee, you should be cautious about pivoting, decelerating, changing direction. That's probably what you do on the side, right? So you maybe put a brace on. So what happens is most people learn how to cope. They're very cautious with that knee, right? So, but you don't want that knee to keep giving out on you, because then that leads to arthritis in that x-ray that we talked about. All righty. It's just as planned. Thank you. Thank you, thank you. Thank you, guys.